Good evening and good morning, and a very big hello to all of you for joining us for the ninth IUSG Uveitis Grand Round webinar. And this time we are coming up with the herpes interior uveitis. This entire webinar is on one particular topic of herpes interior uveitis. You can understand for the simple reason that, you know, on one hand, it has a lot of typical features, a lot of signs that can straight away take you to the diagnosis. But on the other hand, there are a lot of controversies. For example, the diagnosis when the cases are borderline, management, and the biggest challenge remains for us is the recurrence of this particular entity. So welcome to this, and as always, we have the QA section for you. Any questions you have, please keep on typing, and this is for the panelists to take up the relevant questions as per their talks and their cases. So over to you, Alejandra, for the speakers.
Okay, thank you, Rima. Our thematic lecturer today will be Dr. Massimo Accorinti from Vieti Foundation Research Institute from Rome. Welcome, Dr. Massimo.
Hi, everybody. So can I share my screen? Or we are going to present all the other participants, Alejandra?
Okay, then we will have a typical case presented by Elisabetta Miserocchi and his fellow Neophytus Mavris. Then we will have a typical case presented by Dr. Radgonde Amer from Hadassah Medical Center from Jerusalem, Israel, and his fellow Daniel De Geronimo. And then
the names are mixed a little bit, Alejandra.
Pardon me?
So Elisabetta's fellow is
Matteo Meneanna. My fellow is Matteo Meneanna.
Matteo. Okay. So, and then the atypical, and then the uncontrolled glaucoma, Massimo Accorinti. So, can we share the slides?
So can you see my slides?
Yes, Massimo, go ahead. Thank you so much.
So, hi, everybody. Wherever you are in the world, good afternoon, good morning, good evening. It's a great pleasure to stay here and to share with you some practical tips in management of ocular hepatic anterior uveitis. As everybody knows, the herpes family is a big family. It comprises many viruses. But this morning we will speak about the HSV1, varicella zoster virus, and CMV. And although all of them belongs to the same family, they do not share some important epidemiological features, critical findings, and therapeutic approach. So as you will see later, there are a little bit difference even in the presentations as well in the therapeutic management of these patients. So everybody knows that anterior uveitis accounts for 70 to 93% of the cases, of all the cases of uveitis, and the localization of viral-induced uveitis range between 54 to 90% of the cases in anterior chamber. And the percentage of herpetic uveitis among anterior uveitis cases is between 5 and 12%, although these data are coming from two different series in the Northern Europe and one from the away. What about the race? Herpetic uveitis in USA is more frequent in Caucasian than in African American populations. As far as concerned the age, variant anterior uveitis in elderly people older than 60 years old is up to 33% of the cases. And as you can see in the slides, the median age at presentation is quite similar between HSV and CMV, a little bit older in patients for varicella zoster virus. So what's happening in herpetic anterior uveitis over time? These are three different series from Japan. And as you can see here, the herpetic uveitis was 3.7% of all the uveitis in 2002 and raised up to 6.5% in the last surveys done in 2016. So I will address the epidemiology, the clinical feature of each virus separately, as I would like to show you which are the difference and to witness then which will be the therapeutic approach for these cases. Everybody knows that HSV1 seropositivity in patients older than 40 years old range between 80 and 90% of the cases, while HSV2 is quite rare worldwide. And HSV anterior uveitis can develop in all age group, although in Europe and Japan it appears approximately in the 40s and the 50s, while in India it appears even earlier, and the median age is 26 years old. This is more common, the HSV infection in female, with the exception of Northern Europe when female and male ratio is similar. The course of uveitis, HSV uveitis, can be acute, chronic, or recurrent. And as far as concerned, the symptoms of the patient is with pain, blurring vision. They can present serial injection, and in almost all the cases, this uveitis is unilateral. It is important to remember that corneal lesion, even before or after the onset of uveitis, can affect the patients in 30 to 40% of the cases. As far as concerned the signs, we can have medium to large keratic precipitates, medium to severe anterior chamber inflammation. Usually there is a patchy iris atrophy, especially in the recurrent cases. IOP is common. In some cases, you can find hyphema or fibrin in the anterior chamber, posterior seneca in up to 50% of the cases, and vitreous cells. This is a typical case of patchy atrophy in HSV1 herpetic uveitis with a pupil distortion and permanent mydriasis that is usually related to a direct action of the virus on the iris and not to the therapy you may give these patients. And this is a quite more severe cases of herpetic uveitis when you can find corneal edema, patchy atrophy, just in this case, the granulomatous precipitates as well as fibrin and hyphema. So what about vis-a-vis? Vis-a-vis usually affect the elderly population. The mean age at presentation is around 70. There is a little female predominance, but not in all studies. And it may be bilateral. In this paper from Germany, in 24% of the cases, but the second eye is affected by keratitis only and not uveitis. What about the incidence over time? As you can see here, there is an increased incidence by 3.6% per year from 1994 to 2018. But if you look specifically at a different age group, that is people with an age lower than 21 or higher than 60, there is a decreasing incidence over time. And maybe this may be due to a vaccination program. In patients with herpes zoster ophthalmico, we can have a relapse at 1 year in 80% of the cases, in 3 years 70% of the cases, and in 5 years 25% of the patient will relapse. The very important things to know is that ocular hypertension and uveitis is a risk factor for getting a relapsing or chronic disease. Which are the clinical findings? We have to divide them in primary infection that mostly seen in children and in adults. 20% of patients with primary infection can have ocular lesions, and 50% of these are anterior uveitis or keratouveitis. Usually is a mild uveitis, sometimes it is also self-limiting, and it can appear with fine keratic precipitates, small round atrophic spots in the iris, distorted pupil, and sectoral iris atrophy as well, like the HSV. And anterior uveitis in adults may develop either during the skin eruption or more commonly 2 weeks after its onset, and sometimes you can find also a keratic, a corneal involvement. The course also in this case can be acute, chronic, or recurrent. And you should not forget that you can have an herpes synerpete, that means an herpetic infection without the skin eruption. It's almost always unilateral. The 76% is drawing from the study from Germany. As I told you before, the pain, blurry vision, and chilling injection are the most frequent symptoms, and corneal lesion also can occur concomitantly to the uveal involvement. Again, in anterior chamber, you can find the medium to large endothelial precipitates, medium to severe anterior chamber inflammation, focal iris atrophy, as you can see here in the slides, pupil distortion, IOP rise, and posterior synechia. And on the right hand of the slides, you can see the typical Hutchinson signs that is the skin eruption on the tip of the nose. CMV uveitis epidemiology is quite different from all the others. It's more frequent in Asia. And for example, in Singapore, there's been reported that Chinese ethnicity is more affected than Indian and Malaysian one. There is a male predominance, differently from the other type of herpes. It can occur during all the age, but we have to distinguish, as we will see in a minute, the acute recurrent form of the CMV infection from the chronic one. And the mean age at onset, the acute recurrent is 37 years old, while the chronic is 65 years old. Almost all the acute form of CMV infections are unilateral, while in the chronic one, we have 20% of bilateral involvement. So we have to distinguish, because they are completely different as far as concerns signs and symptoms. In acute relapsing, there is a mild Charlie injection, if not at one, few cone-shaped keratic precipitate. There is mild anterior chamber inflammation, usually less than 2+ Flareron cells, and very high IOP, no posterior synechia. Rapid resolution with anti-inflammatory and hypotensive therapy. There is atrophy that is not patchy as in simplex and zoster, but is mainly diffuse. And you can also find endothelitis and very frequent recurrences. And I think that maybe one of the first description of CMV uveitis was done by Postel and Schlossman in 1948, but I would like to acknowledge our founder of the International Uveitis Study Group and president for many, many years, Professor Bloch-Michel, who was the first in the world to look at the possible role of CMV infections in the etiology of Postel and Schlossman syndrome. These are typical features of the CMV anterior uveitis with round, small keratic precipitates. And just in the middle of the slides, you can see how precipitates are located when you have an endothelitis with also Deschamets folds. It's very important to have a look in patients who develop uveitis after cataract extraction. It is the cause in some patients I have observed with CMV uveitis, and you can see how they are located, the precipitate. There are along the incision that you have done for the corneal, and this is the trabecular of the corneal tunnel. In the chronic form of CMV, you can have a Fuchs-like uveitis, no ciliary injection, diffuse light around keratic precipitates, as you can see in the pictures. Flareron cell in anterior chamber, you can have Herpes nodules, no posterior synechia, and the variable vitreous involvement. So it is possible to distinguish in acute uveitis if the patient has a viral uveitis or a non-viral uveitis. We have done with Dr. De Geronimo the study some years ago, and we find that unilaterality, a previous history of keratitis, iris atrophies, and IOP higher than 24 millimeters of mercury are strongly associated to the possibility of a viral etiology of your acute anterior uveitis, while if you have a limited duration of uveitis, chiliary injection, fine keratic precipitate, this is more typical of non-viral uveitis. And you have to look at the significance of these signs, and if you have a unilateral uveitis with IOP higher than 24 millimeters of mercury, you have a sensitivity of 88%, a specificity of 100% to be in front of an herpetic viral uveitis. But if you add also iris atrophy, maybe in the recurrent phase of this disease, your sensitivity will rise up to 94%. Another important thing to address is if PCR is mandatory to diagnose our viral uveitis. We have demonstrated that in a referral center, at least, all the signs and symptoms of uveitis you can find on the left side of your slides are exactly the same if you do a clinical diagnosis or you have a proven acute uveitis. That means a uveitis that has been submitted to an aqueous tap and they have been confirmed by PCR the presence of viral DNA. But if you look at the symptoms and signs, this beautiful paper from Japan, we have collected almost 260 patients in 11 referral centers. There are completely different symptoms at onset of the uveitis. For CMV, you will have less hyperemia than in HSV and vis-a-vis patients, less pain, and less visual reduction. But also, if you consider all the clinical signs, you can have less serum injection, more frequent fine keratin precipitates and cone-shaped precipitates, less inflammation in anterior chamber, and diffuse iris atrophy is typical of CMV uveitis, is not typical of vis-a-vis and simplex, which show usually a patchy iris atrophy. So the diagnosis can be made on clinical feature and the history of the patients you can have, but it's very infrequent in IgM titers or seroconversion. So if you want to be strict, you can go to an aqueous tap and look for PCR or Goldman-Wheater coefficient greater than 3. But please remember that negative results can never be assumed to exclude a viral etiology. Almost 30% of the cases, if you do not tap the uveitis in the acute phase, they may be negative, although there is a virus within the eye. These are the classification for criteria for HSV and vis-a-vis that has been made by the Sun Working Group. I don't want to go into details, but only to show you that if you want to classify an anterior uveitis as due to CMV, as far as concerned this classification criteria, you have to go into the eyes, take a tap, and just prove that there is the CMV DNA within the eye of the patients. So now addressing the topical therapy. We can use topical treatment. Acyclovir ointment has a selective activity, has a good penetration anterior chamber. Ganciclovir ophthalmic gel, again, is a selective activity with a maybe low toxicity as far as concerned the ocular surface, and we will see after why it's so important to look also at the ocular surface. The penetration anterior chamber maybe is less important than as acyclovir. You have to use anti-inflammatory therapy, corticosteroid, but you have to be sure that it's not corneal epithelium damage, because otherwise you can favor the onset of an herpetic keratitis in a patient with a primary herpes simplex uveitis. For example, you should also and always associate the corticosteroid with antivirals, and in some cases that become resistant and dependent to corticosteroid, maybe a long-term therapy with a very low dose of corticosteroid is useful to maintain the eye quiet. Mydriatics, there is no need for mydriatics in patients with CMV uveitis. You can use tropicamide or atropine, and you have to alert that for possible post-herpetic mydriatis, this is not related to the drug you are giving the patients, but only to the intrinsic action of the virus on the iris. The very important thing is to manage the IOP spikes in these patients. You should use topical, possibly preservative-free drugs, no prostaglandins at first line, because it has been demonstrated in few studies that prostaglandin can favor, again, the onset of an herpetic keratitis. And you can use systemic acetazolamide just in the beginning of the IOP spike to take them under control. The other important thing is to preserve a good ocular surface with tear substitutes. What about systemic therapy? In this paper appearing in Ocular Immunology Information, it has been stated that systemic therapy with antiviral drugs should be initiated without delay to control viral replications. And then systemic antiviral therapy is usually combined, as I told you before, with topical administration of corticosteroid, and in some cases, the most severe one, also supplemented with topical mydriatics and cycloplegics. And these are the drugs that you can use. All of them can be given orally. They have different biodisponibility, and the dose you can use is different among the different drugs. There is a suggested duration of induction therapy that range between 7 and 21 days. And there is also a possibility, and we will see later when and why we have to use some drugs to try to lower the recurrences of the herpetic uveitis. All of them can have some adverse events, but usually at the dosage, with exception for valganciclovir, and we will speak later about these drugs, all of them can have very few side effects, even if treated long term. But anyway, you have to check if you are going to give the patients a secondary prophylaxis. You have to check liver and renal functions at least every 3 months during the therapy. Anyway, all the side effects can be managed with a reduction or stopping the therapy if they present with some adverse events. A little bit difference in the therapy for CMV uveitis, as you can see in these slides, and you can have different approach according to if you are in presence of an acute hypertensive uveitis or a chronic one or a CMV endothelitis, and you can use topical ganciclovir either in gel or as eye drop if you want to have a higher concentration of the drugs. And this can be used also in combination with oral valganciclovir. As far as concerns the maintenance phases, please note that if you have an endothelitis or a chronic anterior uveitis, you should keep a very high dose of the drugs during the day. All of these antiviral drugs should be combined with the corticosteroid therapy, and as I told you before, maybe it need for the most resistant and recurrent cases a very long period of corticosteroid therapy. Some authors have also proposed the use of intravitreal ganciclovir 2 milligrams in 0.1 milliliters, 2 to 4 injections, of course, only for the induction phase. And these are the adverse events: ocular discomfort, mild irritation, and tearing if you use the topical one. But please be aware that more than 50% of the patients that you can treat with oral valganciclovir can have hematological disorders, and this is very important to check periodically on these possible side effects. These are one case of resolution, almost all resolution of an HSV1 keratitis, and it is important to look at the precipitates because the more pigmented precipitates can weaken the possibility of a long-standing uveitis, and you have to, as you can see and you can appreciate in these slides, you have a reduction in the corneal precipitates, and in the photos on the right side of the slides, there is an almost resolution of the chronic inflammation because this patient has no anterior chamber flare or cells. And this is how a stromal keratitis related to an HSV infection can resolve with the appropriate therapy. So the question is there any systematic review and meta-analysis that can help us to decide when and with what drugs we can approach our herpetic infection? Yes, there is, 2021, but unfortunately, these are the conclusions that this treatment of HSV and vis-a-vis anterior uveitis is currently based on personal and limited experience and with no possibility of look at systematic review and meta-analysis. They have demonstrated that as far as concerned treatment failures for HSV uveitis, there are only 2 studies that have demonstrated that oral acyclovir prolonged for 10 weeks is exactly equal to placebo. As in, there are more important results maybe for vis-a-vis uveitis, but there is no difference between oral acyclovir and valacyclovir. There is no difference in topical acyclovir versus oral acyclovir. The only thing that maybe oral acyclovir is better than placebo. So, when are the indications, at least for, in my opinion, for anterior uveitis prophylaxis? Maybe in patients with more or 2 or more relapses per year. When the patient has severe corneal scarring, for example, in keratosis uveitis, patients previously submitted to refractive surgery, and patients on corticosteroid or immunosuppressive therapy for other reason other than the eye. This is not the case of the picture on the right side of your screen, but this is one of the patients that I would like to put on prophylaxis because of the very thin cornea after repeated episode of keratosis uveitis. What about vaccine? There are 2 vaccines actually at our disposal to treat the herpes zoster. The one is attenuated like virus, the other one is recombinant. As you can see, both of them can reduce the incidence of zoster and reduce the incidence of postherpetic pain, but the efficacy normally decreases over time by 10% per year, and also the efficacy can change according to the age, as you can find in the green table. So we have to address complications of anterior herpetic uveitis that are mainly constituted by recurrences, number of recurrences, and their frequency, the onset or possible onset of keratitis and dry eye, cataract and IOP rise, but I will address these complications and the management of these complications after Dr. De Geronimo presentations. And I would like to conclude that even you are facing with a simple anterior uveitis, you have to think very seriously about how to make a differential diagnosis, how to approach these patients, how to give a prophylaxis to the most recurrence cases. But you should not forget that although you can fight all your life with all the virus, you will never be able to defeat definitively them. Thank you very much for your attention.
Well, thank you, Massimo. That was wonderful, very elaborate. And I'm sure many of the doubts have already been cleared for the attendees by your lecture. Wonderful tips. So now with this, we move on to the case presentations. We have the first case, which is a typical case presentation by Dr. Matteo Menyon, who's a fellow with Dr. Elisabetta Misucci. Dr. Elisabetta will be the discussant for this case, and they are from University Vita Salute San Raffaele, Milano, Italy. Over to you.
Thank you. Let me share. Can you see my screen?
Yeah.
Yeah.
Okay. So thank you, the International Uveitis Study Group Committee, for this possibility, and thank you, my mentor, Professor Elisabetta Misucci. I will discuss 2 cases of herpetic anterior uveitis in this session. The first case is about a 37-year-old female presenting with pain, photophobia, redness, and remarkable visual loss in her right eye. She has a remarkable history of recurrent oral herpes, and visual acuity in the right eye is 20/80. The pressure is 32, while the findings in the left eye are unremarkable. At slit-up examination, we can see scleral and conjunctival injection and granulomatous keratic precipitates, and most importantly, at transillumination, we can observe iris atrophy. We have a case of acute anterior uveitis, which is unilateral, hypertensive, granulomatous, and it is associated with iris atrophy, plus the history of recurrent oral herpes. Then we did a clinical diagnosis of typical herpetic anterior uveitis. We then performed serology that confirmed our suspicion with positive titers of anti-HSV-1 immune globulins. We started empirical treatment with systemic antiviral, acyclovir 800 milligrams 3 times a day to reduce the viral load and the active viral replication, topical steroids to reduce inflammation and to address uveitis, and mydriatics to prevent synechiae. And we also add IOP lowering drops 2 times a day to address the hypertensive uveitis. In this case, the diagnosis was clinical because we had pathognomonic clinical signs. The treatment was empirical, and we had a serological confirmation. And another confirmation was given once we had a successful treatment response after 2 weeks of therapy. In the second clinical case, we have a 53-year-old male presenting with severe pain and photophobia, redness, and remarkable visual loss in his right eye. But unlike the previous case, he had a 3-month history of unilateral uveitis that was treated with oral and topical steroids without benefit, and it was diagnosed as idiopathic non-infectious uveitis. The visual acuity in the right eye was 2100, the pressure was 28, while the findings in the left eye were within normal limits. Slit lamp examination exhibited conjunctival and scleral injection and epithelial defect with fluorescent stain and stromal edema, stromal corneal opacity, and fine keratic precipitates. Most importantly, we had a stromal immune ring in the corneal stroma, as we can see in this image. In conclusion, in this case, we have epithelial keratitis associated with stromal keratitis and endothelitis, which are unilateral, long-lasting, and hypertensive. We did have the suspicion of herpetic etiology, but given the history of diagnosis of non-infectious uveitis and the treatment of steroids, we decided to perform aqueous tap that tested positive for high-load DNA of VZV. Then, from the suspicion of herpetic etiology, we have the confirmation of typical herpetic keratouveitis, namely a VZV, epithelial and stromal keratitis, and endothelitis. We started the treatment with systemic antiviral, namely acyclovir 800 milligrams 3 times a day to reduce the viral load, but also topical antiviral to reduce the active viral replication in the epithelium. We also addressed the hypertensive uveitis with IOP lowering drops, 2 times a day timolol, and once the epithelial defect was resolved, about 7 days after treatment was started, we added the topical steroids, namely prednisolone 4 times a day to reduce the inflammation and to address the uveitis. This was a quite typical case of herpetic keratouveitis, namely a VZV, epithelial and stromal keratitis and endothelitis, but we decided to have a molecular confirmation given the history of diagnosis of non-infectious uveitis and the treatment with systemic and topical steroids that can be also dangerous given the herpetic etiology. Thank you for your attention.
So thank you, Matteo, and thank you to the IUSG for the invitation. So I'm gonna try to summarize the typical clinical features of ocular anterior uveitis, and I'm gonna just introduce the problem of the ocular herpetic disease, which you already may know that it's one of the most common ocular infection in industrialized countries, but more importantly, is an important cause of ocular morbidity. And the frustrating part of taking care of ocular herpetic disease is that we are still using drugs that are very old, and we are using antivirals to fight against ocular herpetic disease. But in fact, we don't have any type of new treatment that is able to eliminate the virus from our body. So ocular herpetic disease may include anterior and posterior very severe complication, and I'm gonna try to wrap up the typical herpetic ocular disease clinical manifestation. So probably this patient is a sort of example of the challenge in terms of diagnosis and treatment that ocular herpes may offer to you in the clinical practice. Here you have a patient with anterior uveitis, with hypopyon, but you also have a patient with the concomitant corneal involvement with corneal ulcer and neurotrophic keratitis, and also posterior involvement from herpes with vitreitis and macular edema. And I can tell you that when you see a patient like this, you really need to have the courage of treating your patient with a good mix of corticosteroids and antivirals, and still it presents a very important diagnostic and therapeutic challenge. So As I told you, patients with ocular herpetic disease may have an important ocular morbidity due to the fact that they have corneal involvement, and also the quality of life of this patient is severely affected due to the corneal involvement. But as you have seen from Massimo presentation, when the patient presents in the clinic with the unilateral anterior granulomatous uveitis, you have to differentiate between HSV, VZV, and CMV. And sometimes even the skin involvement may help you in differentiating between herpes simplex disease or VZV, as you can see from the patient in the right part of the slides. And I have to remind you that even children may be affected from severe skin involvement from VZV. And again, I have to tell you about anterior uveitis, but as you can see from this table, the anterior uveitis in HSV and VZV may occur predominantly with corneal involvement. So corneal involvement in HSV and VZV may be the typical type of dendritic herpetic keratitis, but you can also have very dramatic corneal involvement like disciform keratitis, corneal ulcer, and corneal ring, as you have seen from Matteo's presentation. In terms of the typical clinical manifestation of anterior herpetic uveitis, you have seen that a patient is typically presenting with unilateral granulomatous hypertensive uveitis associated with corneal involvement and, of course, associated with the iris stroma. But sometime in 5 to 10% of the patient, the herpes may be bilateral, especially in patients with atopy or in immunodepressed patients. And here you can see a young girl with systemic leukemia who had a very severe VZV involvement with not only anterior uveitis, but also a severe retinitis. And this is one of the important points that I have to make for the young ophthalmologists and residents. When you see a patient with a unilateral granulomatous uveitis in the emergency room, you have to look at the back of the eye and you have to look at the peripheral retina, because if you look at the posterior pole, sometimes it can be very difficult because of the large amount of KPs or because of the corneal opacity. But you have to force yourself to look at the peripheral retina, because sometimes you can appreciate patches of retinitis. And in those cases, the diagnosis is even more severe than a simple acute hypertensive uveitis. This is an acute retinal necrosis. So in terms of differentiating HSV1-2 or VZV, they may present similar clinical appearance. Maybe the dendrites in HSV1 may be larger and differently from VZV. But definitely, when you have patients with VZV uveitis, the uveitis may be more aggressive, the iris stroma may be larger compared to HSV, and patient, of course, may present with an associated skin involvement. CIMV anterior uveitis, we have seen the different types of KPs and different types of corneal involvement. But again, when you see a patient with anterior hypertensive unilateral uveitis, you have to think about the differential diagnosis, and Fuchs uveitis is one on the top of the list. But you can see that the KPs are different in Fuchs, and also the iris atrophy is different in Fuchs compared to the herpetic disease. So PCR is definitely the one of the most important tools to have the to find out the DNA in the aqueous humor, and sometimes it can be very helpful. For example, in this patient, which was labeled as a keratouveitis due to herpetic disease, but this patient was not responding to antivirals, and this was the reason. When we did the PCR was negative for HSV, and the patient had keratouveitis due to acanthamoeba. So it's very important to perform the PCR in some cases. So finally, what I can tell you about treatment, Massimo has very widely explained the different type of treatments, but probably the most important point in patient with the anterior uveitis due to herpetic disease is the long-term prophylaxis. because the major problem and the major cause of morbidity is the recurrence, and long-term prophylaxis is the basis to reduce the risk of recurrences of this disease. I'm going to conclude with this case, which, as you can see, it's a simple dendritic keratitis. The patient presented with the small dendrites that resolved, but then suddenly the patient started worsening with corneal ulcer, hypopyon in the anterior chamber, severe corneal involvement, and she ended up with a tremendous eye, with tremendous corneal and anterior uveitis. And this is a case that explained to you how even the most simple typical herpetic patient may turn out in a catastrophic herpetic disease. I thank you for your attention.
Thank you very much for the very nice presentation, Mateo. And thank you for the fantastic discussion, Elisabetta, about typical cases of herpetic uveitis. Now we will move to atypical cases. They will be presented by Neophytus Mavris and discussed by Professor Radgonde Amer from the Hadassah Medical Center in Jerusalem, Israel. Thank you, Neophytus. Yes.
Hi, my name is Neophytos Mavris. I'm a fellow in Hadassah Medical Center in Jerusalem, and today with my supervisor, Professor Amer, we will present you a case on herpetic anterior uveitis with atypical manifestations. A 38-year-old male patient was referred to our emergency department with a 2-day history of non-specific blurry vision in his left eye, accompanied by pain and redness. His ocular history includes low myopia and a retinal detachment repair in the left eye 14 years earlier. He has a medical history of hypothyroidism and depression, for which he is currently receiving treatment, and additionally, the patient reported receiving his second COVID vaccine dose about a month earlier. On ocular examination, the visual acuity was 6.6 in each eye, the intraocular pressure was normal in the right eye, but measured at 40 millimeters of mercury in the left eye. The anterior and posterior segments of the right eye appeared normal. In the left eye, there was an anterior chamber reaction with dust-like keratic precipitates in the inferior cornea and +2 cells. There was no iris atrophy noted bilaterally, and no posterior synechia were present. Fundoscopy did not reveal any pathological findings. The patient also completed an OCT in both eyes, showing that the foveal contour was preserved. Upon reviewing the system, the patient reported no headaches, no fever, no previous skin rashes or eruptions, no diarrhea, no arthritis or ulcers, and no auditory symptoms. Blood tests revealed no leukocytosis, and both CRP and ESR levels were within normal limits. The working diagnosis was Posner-Schlossman syndrome, and the patient was treated with topical dexamethasone and timolol dorzolamide combination to manage the intraocular pressure. During a follow-up visit 1 week later at the uveitis clinic, the visual acuity remained stable in both eyes, and the intraocular pressure returned to normal in the left eye. However, the slit lamp examination revealed medium-sized pigmented KPs in the central and inferior portions of the cornea, along with an anterior chamber reaction and mild atrophy of the temporal iris. During the fundus exam of the left eye, mild vitritis with a bias score of 1 was noted, along with perivascular sheathing observed in the temporal and nasal peripheries. Surprisingly, a small area of perivascular sheathing was observed along the superior temporal arcade in the right eye. The patient also underwent fluorescein angiography. In the angiogram of the right eye, there was no evidence of vascular leakage. The left eye, however, showed diffuse vascular leakage with perivascular sheathing that had been observed previously both temporally and nasally, in addition to a hot disc. So based on the findings of hypertensive anterior uveitis and iris atrophy, herpetic panuveitis was strongly considered, and consequently we decided to initiate antiviral treatment with systemic acyclovir along with systemic steroids. And additionally, we continued the use of topical steroids and timolol dorzolamide to manage the intraocular pressure. During the follow-up exam 3 weeks later, the patient's visual acuity was preserved and the intraocular pressure was within normal limits. There was a total clearing of the KPs and anterior chamber reaction with resolving perivascular sheathing observed in both eyes. Serological tests for syphilis, toxoplasmosis, ACE levels, and a chest X-ray were all normal. However, the IgG test for HSV1 and VZV returned positive results, supporting our working diagnosis of herpetic panuveitis. The IgM antibodies were negative. 3 months later, his vision was preserved and the intraocular pressure was stable in both eyes. The cornea was clear with no keratic precipitates and the anterior chamber was quiet. However, we clearly observed a sectoral iris atrophy developing in the temporal part of the iris and a marked resolution of perivascular sheathing in the left eye. The patient completed a visual field test with no defects detected, and it is important to note that the patient was followed up for a total of 2 years, and while we recommended keeping on a maintenance dose of acyclovir, he stopped by himself, which led to 2 relapse episodes with hypertensive anterior uveitis and no perivascular sheathing. So in summary, this was a case of a middle-aged, healthy man with no preceding herpetic cutaneous eruptions who suffered from unilateral elevated intraocular pressure, iridocyclitis, and iris atrophy during follow-up. All these features are characteristic of herpetic uveitis. However, retinal periphlebitis, present in this case, is a rare and atypical manifestation of this condition. So thank you from my side, and now I will hand it over to Professor Ammer to discuss the case.
So thank you, Neophytos, for beautifully presenting the case. And I would like to thank the leadership of IUSG for organizing these insightful webinars. So as we have learned, herpetic uveitis is traditionally described as being a unilateral granulomatous anterior uveitis. And the points for the discussion today are number 1, the development of retinal periphlebitis, and number 2, the bilaterality. So we know that when the herpes simplex or the VZV viruses, they affect the posterior segment of the eye, the phenotype is known as acute retinal necrosis, which is characterized by the triad of vitritis, occlusive retinal arteriolitis, and necrotizing retinitis. There have been, however, case reports from the 80s and the 90s about retinal vasculitis developing as a complication of chickenpox. And the publication from 1992 reports on the demonstration of VZV virus DNA by PCR in 4 uveitis patients, 2 of whom had retinal vasculitis. This is a more recent publication about retinal periphlebitis developing as zoster sine herpeti, which is very much similar to our case. And the authors describe 2 patients. And I would like to take you through the 2 cases. So we have the case of a 20-year-old healthy woman and the case of a 33-year-old healthy man. Both these patients presented with redness and blurred vision in the left eye. They had drop in vision and the pressure was elevated. In both cases, there was corneal edema in addition to iritis. In the case of the woman, there was frosted branchitis with diffuse retinal periphlebitis, and the man had segmental retinal periphlebitis. The lady had positive VZV IgM and IgG, and the man had positive VZV IgG. However, the diagnosis was confirmed by aqueous tap, which demonstrated the presence of the VZV DNA by PCR. Both patients were treated with combination acyclovir and prednisone. The vision recovered, and the lady developed iris atrophy 2 months later, whereas the man developed iris atrophy 3 weeks later. Both of these patients declined having previously developed VZV skin eruption. The man, however, did have varicella infection before, and therefore the authors hypothesized that it could be that because of the man's previous exposure to the VZV, he developed a localized form of retinal periphlebitis, whereas the woman, it was her first exposure to the virus, and it is possible that that was the reason that she developed diffuse retinal periphlebitis. So they were two healthy young adults without the cutaneous eruption of herpes zoster, so it was a zoster synherpeti. So regarding the anterior segment, they had the classic features of herpetic uveitis with iridocyclitis and the unilateral increase in the IOP. However, the patients had also retinal periphlebitis with no hemorrhages and with no arteriolitis, which is the feature of acute retinal necrosis. The diagnosis was confirmed by showing the VZV genome in the aqueous humor, and both developed iris atrophy in a later stage. Actually, when we look at the literature, we do find cases of retinal vasculitis even in immunocompetent children. So this was the case of an 11-year-old healthy girl who presented because of progressive visual loss and photophobia in the right eye. She had a mild decline in the vision. She had mild granulomatous anterior uveitis, and the IOP was slightly elevated. Fundoscopy, however, of the right eye showed diffuse vitritis, marked vascular congestion, and fluorescein angiogram showed diffuse vascular leakage. So the girl was empirically treated with intravenous acyclovir and 1 intravitreal ganciclovir injection. Serological tests showed positive HSV and VZV IgG, and the diagnosis was confirmed by aqueous tap showing positive VZV DNA. So the girl was treated with a combination of acyclovir and prednisone, and the vision eventually recovered. And as you see, also the fluorescein angiogram 6 weeks later shows complete resolution of the retinal periphlebitis. In this publication in Ophthalmology 2003, there were 37 patients with chronic refractory posterior uveitis, in whom the authors performed aqueous tap, and surprisingly, 5 of these patients had diagnosis of viral infection. 4 of whom were women. They were immunocompetent individuals. They had HIV negative, and in 4 out of the 5 cases, it was a bilateral disease. The phenotype of the disease was mild to moderate vitritis with diffuse retinal vasculitis, papillitis, and CME. So the PCR revealed positive VZV genome in 3 patients, HSV1 in 1 patient, and HSV1 was diagnosed by local antibody production in the 5th patient. So the authors suggested that we need to rule out viral infection in patients who have long-standing posterior uveitis that is resistant to the immunomodulatory therapy, and that these patients have a negative previous workup. This other publication is from Tunisia. It's a very important paper on 45 patients with herpes zoster ophthalmicus. And 6 out of these 45 patients, meaning 13%, had bilateral simultaneous herpes zoster ophthalmicus with both eyes affected. However, if we look at the characteristics of the patients, we note that 2 had diabetes mellitus, 2 were in immunomodulatory therapy, 1 patient had HIV, and 1 patient was healthy. So when we have such a presentation with a patient having bilateral anterior uveitis and bilateral herpes zoster ophthalmicus, it is straightforward to make the diagnosis. However, it is much more challenging if the patient has bilateral hypertensive anterior uveitis and without the classic skin eruption, as in this publication of a 65-year-old man, and the diagnosis was eventually made by detecting the VZV DNA in the aqueous by PCR. Bilaterality has also been described with herpes simplex virus, and this publication from Turkey, on 111 cases, 3 patients had keratouveitis bilaterally, and all these 3 patients had atopic disease. This is another publication by Elisabetta in which herpes simplex virus was detected bilaterally in 18% of the cases. And this case series by Alejandra on 3 patients who developed bilateral herpes simplex uveitis. You see patient number 1 had HSV2 meningitis before, and she was a patient who was on immunomodulatory therapy because of Sjogren and lupus. Patient 2 and 3 were initially diagnosed to have non-infectious uveitis, and they were treated with immunomodulatory therapy, and eventually aqueous TAP confirmed the diagnosis. Therefore, the authors suggested that the immunomodulatory therapy favored the extension of the infection bilaterally. So the question is, was our patient immunosuppressed? Just to remind you that the patient developed the uveitis around a month after receiving the COVID-19 vaccine. This UK case series is about 10 patients who developed herpetic eye disease following the first dose of the COVID-19 vaccine. In 4 patients, it was herpes keratitis, and in 6 patients, it was VZV keratitis, and in around 60% of the patients, they also had anterior uveitis. Well, when we look into the literature, we see that there is reactivation of herpes zoster keratitis also after other types of vaccines, for example, after VZV vaccination and also after influenza vaccination. So in summary, the cause of retinal periphlebitis during VZV anterior uveitis remains unexplained. Clinicians need to carefully evaluate the posterior segment every time herpetic anterior uveitis is suspected. We need to examine the fellow eye, and we need to look for an underlying etiology that triggered the reactivation of the infection. And I would like to thank you very much for your attention.
Thank you, Redgonde, for the wonderful cases and for the wonderful case discussion. So with this, I'm sure even I have some questions for your cases, so we'll take up the questions at the end. And with this, we now move on to the last part of the case presentations, and it's a pleasure to have Dr. Massimo back with his fellow presenting the case, Daniel Di Geronimo, presenting case on uncontrolled glaucoma. And it's again a privilege to share with our attendees. Dr. Massimo is the treasurer of IUSG. So over to you, Daniel, and then Dr. Massimo.
Are you be able to hear me? Sorry.
Yes, please.
Okay. So the subtitle of this clinical case is The Never-Ending Story, and you will soon understand why. These are my disclosure. Everything started in more or less 50 years ago, in the far 1975. The patient was a male, 29 years old, and he complained 3 episodes of blurred vision, mild hyperemia, and halo surroundlights on the right eye in the previous 3 years. At the first observation, the visual acuity was 20/25 in the right eye with -9 refraction. And he had mild cellular injection, rare endothelial precipitates, mild inflammation in the anterior chamber, clear vitreous, myopic macular dystrophy, and the IOP was increased, 38 millimeters of mercury. Perfectly normal the other eye. So the diagnosis was unilateral hypertensive anterior uveitis that was treated with topical steroids and hypotensive drops. In the next 10 years, the patient had 24 lapses of hypertensive anterior uveitis, and the maximum IOP spike described was 56 millimeters of mercury, treated every time with topical steroids and hypotensive drugs, so not chronic therapy for the hypertension. This was a visual field at the end of these 10 years, so quite normal in both eyes. And so we have a patient with recurrent episodes of a unilateral rise in IOP that are out of proportion with a minimal intraocular inflammation. So this is a case of the Posner-Schlussmann syndrome. In the next 2 years, the patient had 4 lapses of hypertensive anterior uveitis in the right eye, but be careful that in 1986, the patient had the first increase of the pressure in the other eye, so in the left eye, 24 millimeters of mercury without uveitis. So he was started on timolol twice a day as chronic therapy for the left eye, so the other eye. In 1987, this was a visual field. So we have the first visual field changes in the right eye. And in the same year, he has in few months 4 lapses of anterior uveitis with the chronic IOP increase, more than 24 millimeters of mercury, in therapy with timolol twice a day, dipivefrin 3 times a day, acetazolamide 250 milligrams, 1.5 tablets a day. So the patient underwent in June of the same year to trabeculectomy in the right eye without mitomycin that was not available at that time. And the result was good because few months after the trab, the visual acuity was 20/25. The IOP was good, 10 millimeters of mercury without therapy. And this was the visual field, so much better than the previous one. Since 1987 till today, the patient has had no more relapses of anterior uveitis in the right eye. So in 1991, this was the condition of the eye. So the IOP was good without therapy, but looking on the visual field, you can see here a symmetric reduction of the sensitivity in the infranasal sector of both eyes. So what was going on? A CT of the skull and sella turcica highlighted an arachnoid diverticulum. So the diagnosis of empty sella was made, and but without neurosurgical and endocrinological implication. The patient remained stable for more than 10 years. 1 year later, in 1998, the patient had the first new increase of the pressure in the right eye, 25 millimeters of mercury. So he was started on timolol twice a day in the right eye with reduction of the IOP. But after a few months, a new increase of the pressure was found. So brimonidine was added to timolol, but the patient had allergic reaction to brimonidine. So brimonidine was changed with prostaglandin. So with a good final control of the IOP, you can see here also the diurnal IOP variation with good values of the pressure in both eyes. The patient remained stable in the next years. In 2005, the IOP was stable on therapy with timolol, dorzolamide, and prostaglandin. The visual field was stable. You can see here also the pachymetry values that were absolutely normal, but he had reduction of the visual acuity in the right eye to 20/40 because of the cataract. So the patient underwent the cataract surgery in the right eye in April 2005, and then during the surgery also an aqueous tap was performed for searching viral DNA by means of PCR. And you can see also the IOP values of before and after the surgery that were absolutely normal, so with good control of the IOP close to the surgery. But the patient had in the next year a severe allergic reaction to all the hypotensive drops with chronic conjunctivitis. So all therapies were stopped with increase of the IOP in the right eye and 34 millimeters of mercury, and the left eye 20 millimeters of mercury. So be careful that for the patient was not possible take more than 1 tablet a day of acetazolamide due to some suspected urinary stones. So with only 1 tablet a day of acetazolamide, the pressure was 24 millimeters of mercury. For this reason, the patient received a new surgery in the right eye, a new trab, this time plus mitomycin, so 19 years after the first trabeculectomy, with good result because the IOP after the trabeculectomy was 13 millimeters of mercury without therapy. But 3 years later, the patient had an infection of the bleb, Uveitis. You can see here the report of the emergency room where a ciliary injection took place close to the bleb, CD positive, flaring cells in anterior chamber were described. So the diagnosis of hyperfiltering bleb infection was made, and the patient was treated with systemic and topical quinolones for 15 days, oral steroids, atropine, and bandaging with reduction of the inflammation. But in February and March, also an apposition on a double-layered amniotic membrane was done with good control of the IOP and the resolution of the saddle from the bleb. But the patient had new episodes of conjunctivitis. So in the same year, a revision of the bleb was performed in June 2009 with good control of the IOP that was 15 after therapy and also good visual acuity that was 20/20. So the patient remained stable in next years till 2013 when the IOP increased to 21 millimeters of mercury in both eyes. So the patient was started on timolol twice a day again in both eyes with a reduction of the IOP. And in the same year, he had also cataract surgery in the other eye, so in the left eye. Be careful that in all these years, the patient had other ocular comorbidities like recurrent chalatia in both eyes, and he received also different surgery for chalatia. And in 1995, also narrow laser treatment for the retinal tear in the left eye, in the other eye. These are the visual field changes in both eyes between 2015 and 2017, so with mild progressive improvement of the visual field in both eyes. And this is last time we saw the patient a few months ago in August. So you can see here the visual field that is not too bad for a patient with an history of 50 years of glaucoma. And this is the anterior segment of both eyes. The visual acuity of the right eye is 20/25 with a posterior capsule opacity. So visual acuity could be also better than this, and 20/20 in the other eye. The IOP is good in both eyes, 15 millimeters of mercury in the right eye and 16 in the left eye. And the patient is on timolol twice a day in both eyes. This is the condition of the bleb. And this is the last diurnal IOP variation, so with good values in both eyes on timolol twice a day. This is the back of the eyes. So a brief summary on the clinical history of the patient. In the right eye, he had 52 years of uveitis and glaucoma, 35 relapses of anterior uveitis, 1 blebitis, and relapsing chalatia. In the left eye, 37-year or ocular hypertension, retinal break, and relapsing chalatia. On the right side here, the surgical history of the patient with several surgeries for him. So what's next? And Professor Accorinti will tell you the end of the story. Thank you so much for your attention.
Okay. Can you hear me?
Yes.
So can you see my slides?
Yes.
Okay. So before addressing specifically the case presented by Dr. De Geronimo, I would like to come back to my last slides. That is the complication of anterior hepatic uveitis. As you have already heard, we have problem with recurrences and the problem with cornea involvement and dry eye. We can have problem with cataract, and we have problem, of course, with IOP rise and glaucoma. All of these topics can affect the outcome of any surgery or any medical therapy for herpetic uveitis with IOP rise. Why? Because the higher is the number of IO peaks and the higher is the number of recurrences, the higher is the chance to have a diagnosis of uveitic glaucoma. And on the other hand, it has been demonstrated by these authors coming from Turkey that if you treat acute herpetic uveitis for more than 6 months, you can significantly reduce the number of relapses. So the question is are there any other risk factor for herpetic uveitis recurrences? According to the herpetic eye disease study published in 2001, there is no relationship between psychological stress and other potential trigger factors for the recurrence of herpes infections. But more recently, there are some reports that stress the relationship between psychological stress, light exposure, overweight, and obesity in the occurrence of herpetic eye disease. What about keratitis? As I've already told you, 30 to 40% of the patients, especially those with HSV infections and also as CMV infection, can be complicated by the onset of a corneal involvement, an infection of the cornea, an inflammation of the corneal involvement that can appear as a herpetic dendritic ulcers, as you can see in the left side of the slides, stromal keratouveitis in the middle, and also with only a stromal keratitis in the right hands of the slides. It's very important to address it, to consider the possibility of dry eye in these patients, because dry eyes can be due either to the chronic topical therapy with corticosteroid or antivirals, as in these cases, it was unfortunately a young ophthalmologist with an herpetic uveitis, and also to the presence, for instance, of a bleb or any filtering procedures, because when you have a bleb, the tear film does not cover completely the ocular surface, and you can have a very severe dry eye with an important reduction of visual acuity. And this is an example on how you can just rehydrate the corneal and restore the clarity of the cornea itself. The other problem is cataract. Cataracts can be either subcapsular or mixed with the corticonuclear and subcapsular in older patients, for example, those with vis-a-vis uveitis or keratuveitis. And in this case, you should also be very careful, because as you can appreciate in the picture on the left side of the slides, there is also a bleb in these patients. So we have to consider the possibility of failure of the bleb after your surgical procedure with the cataract. So going back to the tips of management of herpetic anterior uveitis, you should, and it was one of the questions that I've already replied to, you should use a preoperative prophylaxis systemically in order to reduce the occurrence of relapses of uveitis after the surgery, because if the patients do not have already a glaucoma or an ocular hypertension, they may develop this in the follow-up. You have to use non-steroidal inflammatory drugs, for instance, if you want to prevent the occurrence of macular edema, with very caution, because it has been demonstrated that also non-steroidal inflammatory drugs, as prostaglandins, can favor the occurrence of an herpetic disease, a herpetic superficial disease. Please go ahead with a phaco clear cornea incision and mine the tunnel, not burn it. So be as fast as possible in order to reduce the corneal damage that you can induce with your operator. The other problem is the management of mydritis. It's very easy in the patients like here in the picture, because you don't need to dilate anymore the pupils. You can go just through this size of pupil to do your surgery. And please also use a postoperative antiviral therapy for at least 1 to 2 months after the surgical procedure in order to reduce as low as possible the chances of relapses. And you have to protect the cornea during and after the surgery, because as everybody knows, after the cataract surgery, in normal patients, in old patients, we can have a disturbance of the ocular surface for as long as 6 months after the surgery itself. So what about glaucoma? So going into the specific discussion of the cases, we all know there are different pathogenetic mechanisms of glaucoma in all uveitis, especially in the viral one. There is inflammation of the trabecular measure, trabeculitis, that is typical of the acute phase, and in which the angle is open. Steroid induced, again, that is typical of the relapse on chronic phase, especially if you use corticosteroid long term. The angle is open, gonioscopically open, of course, it is closed within the trabecular measure. Then you can have a closed angle, even either partial or complete, in relapsing chronic phase because of the formation of an anterior synechiae or posterior one. But usually you have a mixed mechanism in all patients with uveitis and also in patients with herpetic uveitis. So going back to discussion of the cases, the time zero is 1962, and the diagnosis at the time was Post-Schosser syndrome. We don't know at that time that Post-Schosser can be caused by CMV or other virus infections. So the therapy at that time was done only with hypotensive drugs and steroids. And we have to underline that it is, are we sure that it is a benign course of uveitis? We have observed 35 relapses in 15 years of follow-ups. That means more than 2 relapses per year, and 0 relapse in additional 37 years of follow-up after trabeculectomy. But we don't know if there were no relapses. We are sure that in our chart there is no indication of any relapses when we have examined the patient, but we don't know if an IOP spikes and very mild symptoms that is characteristic of the CMV infections can have occurred between one relapses and the other. The other important things to address is an IOP problem in the other eye. This is not related to any inflammation. As Dr. De Geronimo has told you, the angle is open. So maybe, and this is the case in which you should never forget to look at both eyes, even if you are dealing with a unilateral uveitis. The other important things that is quite usual in patients that you submit to for any filtering procedure, that the filtering procedure can fail over time, and this was one, in our case, it appears after 11 years after the first trabeculectomy that was done without mitomycin. Then the patient has experienced a cataract because he is myopic patient and because he is getting older. But 1 year after surgery, we have an IOP rise. So what does it mean? Does it mean that maybe the surgical procedure for cataract has increased the possibility of a failure of the trabeculectomy? So we have to, and on the other hand, the patient presented an allergic reaction. So we were compelled to done another trabeculectomy in this patient, this time with mitomycin. One of the possible complication of any filtering procedures if you use mitomycin C is an hyperfiltering bleb, and 3 years after, our unfortunate patients develop a blebitis. We do a bleb revisions, then cataract in the other eye, and finally is on timolol both eyes with a control of his intraocular pressure. But you should never forget that the patients can have some other problems not related to the uveitis, such in our case an empty cella, or some other problems in the eye that are not related again to uveitis, such as calatia and retinal breaks. So what can we do in a patient with uveitis just to be sure that we are controlling very well the IOP? We have to look for diurnal spikes because it has been demonstrated that diurnal spikes are greater in patients with uveitis than in those with primary open-angle glaucoma. But unfortunately, no diurnal spikes we have observed in our patient during all the follow-up. The other important thing is to look carefully at the visual field because we know that patients with uveitis have a rate of progression that is greater than those with primary open-angle glaucoma, and the relative risk of being a fast progressor as far as concerned the visual field defects are the double in patients with uveitis rather than in those with primary open-angle glaucoma. We have observed in our patient fluctuating visual field defects, and we will see why. So what about the medical therapy? This was another questions that I have already replied to. You can use all the drugs you have at your disposition, avoiding pilocarpine because it can increase the inflammation in your eyes. But you should be aware that all of these drugs can have side effects, local side effects. And the one highlighted in red are those that can be a confusing factor if you are treating a patient with an herpetic uveitis, because some of them can induce reduced corneal sensitivity, corneal edema, dry eye that may complicate our cases, and even corneal erosions and ulcers. We can do SLT in a patient. This is not the case of our patient because we have managed it before the SLT was widely available, although we have to remember that there is not so a good response to SLT, especially in patients who have been treated previously with some medical drugs, and the success rate at 12 months is 1/3 of the cases, 27% of the cases. It has been tried also in patients with uveitic glaucoma, and it is depicted here in the purple column. And as you can see, although the pressure was not so high, the median pressure is 22 millimeters of mercury, it has been a decrease in the number of in the IOP value. But if you look at the number of medication, there is a significant increase of them in order to maintain a good control of IOP. Another study which has used a high energy selective SLT has shown that the success rate at 12 months is more or less 60% of the cases, but no one of these patients has had an herpetic uveitis. I don't want to go into details about peripheral iridotomy because it's not the case of our patient, which has shown an open angle, but you should keep in mind that laser iridotomy is less effective in patients with uveitis compared to patients with angle closure non-uveitic patients, and 60% of the patients with uveitis can fade after a median survival days of 85 days. On the other hand, there is another report that clearly showed that surgical iridectomy, if you need, is better than iridotomy in patients with uveitis with a longer survival. So I don't want to, we have time to go over all the glaucoma procedures, but I would like only to say two things, see which are the risk factors for failure of glaucoma surgery in patients with uveitis. There is mild sex, age lower than 45 years old, and prolonged post-op inflammations, and especially in trabeculectomy, one single episode of uveitis after surgery increased the surgical failure by 5-fold. We have seen in our patient one of the most worrisome complications, that is the onset of blebitis, that is medium-term or late complications. And if you go to minimal invasive drainage implants, such as the Express, Xen, or Preserve 4, whatever you want, you can have also an erosion of the sclera, in this case of an Express implant. And if you need to lower the pressure to the low teens, you can just think about a long tube, say drainage devices. There are many on the market, and although they are very useful, don't forget that we are treating young patients with a very good immune status, so they can just have inflammation related to the position of the tube, and especially scleral erosion, as you can see in the right side of the slides. So which are the tips and tricks for addressing the glaucoma? Please look at the timing. Maybe you have to consider that the higher number of the drugs you use before the surgery, the higher is the possibility of a filtering blade failure because of the inflammation, subtle inflammation of the conjunctiva. You have to use a preoperative antiviral prophylaxis systemically and control very well the inflammation, because inflammation before the surgery can lead to a failure of your filtering procedures. You have to choose the most appropriate technique according to your patients, and please consider target IOP that should not be maybe 20 in a patient with uveitis, as it was for patients with glaucoma, but we have to lower the pressure, especially if there is a visual field defects before the surgery, and consider the less invasive procedure and think about the future, because you can follow the patient for 50 years, as Dr. De Geronimo has told us. You have to use post-operative prolonged antiviral therapy, because corticosteroid is mandatory if you do any filtering procedures for at least 6 months after the procedure itself. And please consider to protect the cornea either during and after surgery, because the drugs you are going to prescribe to the patients and the presence of the bleb will alter the ocular surface. So in conclusion, in case of acute anterior hypertensive unilateral uveitis, you have to think of an herpetic infection, make a clinical differential diagnosis, and then proceed to more invasive and expensive tests. And in all patients with uveitis, remember that the eye is only 7 grams in 50, 70 kilograms of human being. You must remain a doctor. You have to think of the general health of the patients, not only at the eye. If IOP is high, go with a gonioscopy or anterior segment OCT if you have, and it is mandatory. Visual field follow-up is essential in all uveitis, hypertension, or glaucoma patients, although some of the defects, as in our cases, can be attributed to IOP. And in patients with unilateral uveitis, always take a careful look at the other eye. So although our patients has had to fight against IOP for all his life, these are the picture he has sent us just to demonstrating how he's enjoying his life after retirement. Thank you very much for your attention.
Thank you, Dr. Massimo.
Thank you. What a difficult case. Thank you so much for sharing it and leaving us with these reflections and lessons. Fantastic discussion, Massimo.
Thank you very much.
So we have some questions. I'll take up some of the questions that are still pending in the QA and that have been mostly asked in the QA. First to you, Dr. Massimo. You've shown beautifully how the different anti-glaucoma drugs, their side effects, so if one has to ask, what is your choice of anti-glaucoma in glaucoma, viral anterior uveitis? Somebody asked about Alphagon, but I would pose a general question. What is your choice and why?
Well, I think that most of them depends on the systemic pressure of the patients. Because you can use brimonidine, Alphagon, if you want to, this is the commercial market name, but you have to keep in mind that brimonidine can have an effect on the systemic hypertension. So if you have a patient with a normal hypertension or systemic hypotension, you give him or her brimonidine, you can lower the pressure, and then there is an imbalance at the level of the optic nerve. So be careful before. This is not my first choice in patients with uveitis. So I would like to go straight to a beta blockers and Zolamed, a combination of them if you need. Then you can add brimonidine or prostaglandins, just choosing about the systemic condition of the patients. So be aware that you should remain a doctor for all your life, not only an ophthalmologist.
It's a very important point. Thank you, Dr. Massimo. So I'm over to Dr. Elisabetta. Again, a lot of controversy about serology, IgG, IgM. So it's not about what to do. How would you choose serology in your clinical practice, and when would it influence your treatment?
Usually, I always ask serology for confirmation of the clinical diagnosis. So I ask for IgG and IgM titers for HSV, VZV, and CMV. And then when I found the positive IgG titers, I confirm my clinical diagnosis and I continue the antiviral treatment. But of course, there are a few cases in which I found also the IgM positive titers, especially in VZV patients. And in that case, I use serology only for confirmation of the disease, but then I do not follow the IgG and IgM titers during the disease.
So in case both the titers are negative and you still clinically suspect viral anterior uveitis, whether simplex or varicella zoster, would you still go ahead with the same treatment as you would give for a positive serology?
You mean if I found a negative serology?
Yeah.
Well, sometime if I find the negative serologies and the clinical picture is highly suspicious for HSV or VZV, I start antivirus and I continue antivirus. But then I try to repeat the serology, and then if the serology is negative, I have to think about other diagnoses. So, for example, toxoplasmosis is something that can present with anterior granulomatous uveitis, of course, with the typical chororetinitis, but then sometimes the challenge is between viral and toxo, or between viral and acanthamoeba, as I showed you in the clinical presentation. And so I really trust for the first clinical diagnosis, but then if at some point the exams are negative, I have to think something else.
Okay. And Professor Ramir, for your wonderful atypical cases, I mean, you showed beautifully the patients had periphlebitis, but then again, it's my question also, and there is a question in the QA section. There was no vitritis. So what made you think of, because when we see posterior segment of these cases, there are no hemorrhages, no exudates, no sheathing. So what made you think of doing a fluorescein, which led you to diagnose a periphlebitis? Because generally these cases would just pass on as only anterior uveitis.
A very nice question and very important. And as highlighted in patients with herpetic anterior uveitis, we always need to check the posterior segment. I think also the previous speakers emphasized that, since patients might develop with posterior segment involvement. And we know that vitritis is common with VZV much more than with HSV, but also it's common. And it's very important to look at the posterior segment. The patient did have vitritis, and we did see the perivascular sheathing. That was the reason why we performed fluorescein angiogram, because we wanted to understand what really lies behind this atypical manifestation of perivascular sheathing, which is not something that we hear about, when we speak about patients with herpetic anterior uveitis. So it demonstrated to us that there is inflammation. We didn't see signs of ischemia. We didn't see any other pathological finding to explain the perivascular sheathing. That was the reason that we correlated it with the presence of the herpetic anterior uveitis. So when we looked into the literature, it seemed actually a case that repeats itself. With the two cases that I presented with the retinal periphlebitis in patients with zoster synherpeti, it's a copy and paste presentation of the two cases. And also you saw the case of the girl who had really marked a retinal periphlebitis as well. So it's very important to know that some patients may develop this feature, and it's not connected to acute retinal necrosis. And that was the reason that we were safe. We felt safe in continuing the medication, in continuing the Zovirax, the acyclovir, and the prednisone, and we didn't actually had to performing aqueous tab, because the patient did respond very nicely to the antiviral treatment.
So one take-home message from your cases is, because sometimes, the curatic precipitates in viral anterior uveitis, they may be diffuse, they may be large, and they often pigmented. So we may not be able to see the posterior segment as sharply for a perivascular sheathing, which is subtle. So what I would recommend to our attendees is that during the initial episode of massive KPs, even if you're treating topically, they disappear. Usually they would disappear by a week. It would be worthwhile to again check them for a dilated fundus examination so as not to miss the perivascular sheathing, which would be obvious after the resolution of the KPs. Alejandra, any questions from your side?
No. Massimo, I think you...
Yes, can I make a comment on serology? So I think it should be useful to check for all the virus, not only HSV or vis-a-vis, but CMV and Epstein-Barr again, and HSV too, because in some cases, if you have a complete negative serology for all the viruses. We have to think about immunosuppressed patients. So we have to check for the immune status of the patients, because you can have negative serology with a positive herpetic uveitis or whatever you want. So if you have a negative serology for all the virus, this is quite uncommon, at least in our country, to have to not to have any IgG. So we have to recheck, as Elisabetta told you, in some weeks after the onset of the uveitis, just for the appearance of hopefully an IgM titer. But we have also to check to all the virus, because if the patient was negative for all the virus, no IgM or no IgG, you have to check carefully at his immunostatus, because the therapy can change it, and you have also to make, in such cases, an HIV test, especially if the patient presents a zoster infection, zoster cutaneous infection in people younger than 40 years old.
Very good point, Massimo. I agree. And how often do you ask for labs to check the hepatic, renal, and hepatic function?
Well, this is very important if you go in the secondary prophylaxis. So every 3 months, 3 to 4 months is mandatory, just to check. Independence also on the age of the patients. The older is the patients, the shorter is the period between the two that you have to repeat the examinations. The younger is, it is usually the secondary prophylaxis with acyclovir. There was a topic of another question, when I choose acyclovir and when I choose valacyclovir in these patients. And my answer is you should go with acyclovir first, because although rare, you can have some resistance to acyclovir. So don't go to valacyclovir before having try a first course of acyclovir. You can just change your mind. You can just change the drug if the patient is not responding and if he's presenting frequently recurrences. And don't forget that if the patient is frequently recurrent, check his or her immunostatus.
Great points.
So I think before we wind up, I'll take up 2 questions for all the panelists, open to Massimo, Redgonde, and Elisabetta. When do you add acyclovir ointment in case of herpes anterior uveitis?
Elisabetta?
When there is associated corneal involvement, so for example, if you have epithelial keratitis, you have to start first of all with topical acyclovir ointment, and also if you have cases with aggressive corneal ulcer, you have to start every time that there is epithelial disease. I would add the topical antiviral ointment, and then you have to wait until the epithelium heal to start then the slow tapering, slow administration of topical corticosteroids to reduce the inflammation. Those are very difficult cases because the balance between the administration of steroids and topical ointment and systemic antivirals are very difficult to judge in the patient, and every patient has a different type of response to this 2 type of treatment.
But Elisabetta, is there any role for topical treatment if there is only uveitis without corneal involvement?
No, I don't give topical ointment antivirals if you only have anterior uveitis. There is no reason.
Okay, thank you.
It's always prescribed when there is an epithelial disease. I mean, it has a very good effect on the corneal epithelial disease, whereas if we have stromal, endothelial, or anterior uveitis, the treatment needs to be systemic acyclovir therapy.
Absolutely, yes.
And what is your regimen for herpes anterior uveitis, the first episode, simplex versus varicella? So you have a case of herpes simplex anterior uveitis. How would you treat? What dose of acyclovir and for how long? Redgonde?
For the VZV, classically, the dose is higher than the dose that we use for the herpes simplex. In case of using acyclovir, we do use 800 milligrams 5 times per day. for the VZV, whereas for the herpes simplex, we use the 400 milligrams 5 times per day, at least for 10 to 14 days, after which we would like to taper gradually the treatment. We prescribe the medications at 3 times per day, maybe for around a month, in order to understand if whether this patient will develop subsequently reactivation as we are tapering down the medication. Because I think it's a common, as we have seen, it's common scenario to have chronic infections and to have recurrent infections. So instead of having the patient suffering from another hypertensive attack in which the IOP would go very high and damage the optic nerve, we would rather keep the patient at least, for the first month or two, in order to observe the way that he is responding to the treatment. If we see that the patient has a favorable response to treatment, we would like to continue and taper. But we do this actually very gradually, and we observe and we monitor the patients, especially the ones that presented with iris atrophy and with elevated, marked elevation in the intraocular pressure.
So can I say that the first episode of viral anterior uveitis, whether it's herpes or varicella, we would go on with the systemic acyclovir for maybe 4 to 6 months, of course, with tapering. So when to stop? Would it be 4 months, 6 months, anything, Dr. Massimo?
Well, I think that you have to differentiate from simplex and zoster, because maybe for zoster, valacyclovir is more indicated. It's more useful, and there is less drugs, less pills that you have to take over time. So I will go over with the 3 grams, at least for 15 days. It depends also if there is also a cutaneous involvement, and what about the pain? Because if we have an herpes zoster, we have to look at the uveitis, but we have to look over postherpetic pain that may be addressed with corticosteroid systemically. And if you give a systemic corticosteroid in a patient long term, you will immunosuppress him or her. So the problem is that the length or the duration of the therapy you should give to your patient, it depends of all the lesion you can have. You can have an herpes zoster with a very, very severe pain. You can have over prednisone 25 to 50 milligrams a day for at least 2 to 3 weeks. You have to keep on with the maximum doses of valacyclovir, for example, for even 1 month, and then decrease gradually. Because think about, if the herpes zoster is an older patient, older people are usually immunosuppressed compared to younger. This is the first consideration. And the second one, that if you have an herpes zoster in a very young patient, maybe it is a local or systemic immunodepression, even is not demonstrated by your exam. So keep the duration of the therapy according to all the manifestations of the zoster. If I have an herpes simplex uveitis, I will go with very high dosages, because usually we see patients that are sent to referral center because of relapsing uveitis. It's not the first episode. But if you decrease the viral replication as fast as possible, for instance, giving them 4 grams per day of acyclovir for 15 days, that you can decrease to 2.5 grams for additional 15 days, and then decide if you need to go for secondary prophylaxis with 800 milligrams per day.
So thank you. With this, we come to the conclusion of our 9th webinar. And thank you all the attendees. We see a very good number of participation. And we would be happy to invite you for the next webinar, which is on December 14th, which is on acute retinal necrosis. Until then, goodbye and have a safe day, good night. And thank you very much to all the speakers for their wonderful cases, wonderful tips and tricks, I would say. And I think lovely messages for the attendees. Thank you, Alejandra.
Thank you.
Thank you
So
to
much.
Thank
All of you. Fantastic webinar. Thank you for the panelists and the fellows.
Thank you, everybody. It was great webinar. Thank you very much.
Thank you.
Bye.
And
Thank you.
Bye-bye.
Thank you.
Bye.
Bye.